My name is Rajeev Kumar. I'm a neurologist and a movement disorder specialist. I practice in the Denver, Colorado area, and I'm the director of the Huntington Society of America Center of Excellence at the Rocky Mountain Movement Disorder Center and Movement Disorders Foundation. So with respect to safety, we found that generally this was a safe medication. However, there were some serious adverse events that occurred only in individuals who at baseline had a positive ANA antibody titer. And in those individuals, we found that one patient developed hemolytic anemia that was mildly symptomatic. We had one patient who developed a drug-induced lupus-like syndrome, and one patient who developed autoimmune pneumonitis. All of these individuals have recovered quite well following discontinuation of the therapy. In general, all of the patients during the loading of the drug develop a rash, which is a pseudo-allergy due to complement deposition in the skin. And the initial loading takes place during a continuous infusion that takes about 23 hours. So it's a long infusion initially. Thereafter, patients are administered the antibody approximately every 2 weeks during an infusion. At least in this study, the infusion time was 5 hours. This was well tolerated, and there were only minor adverse events that were not significantly drug-related beyond the 3 individuals who developed an autoimmune-like syndrome. So after the loading dose, we saw complete target engagement with knockdown of all complement activation. So that was the first thing. We saw that this has a long duration effect, and by administering the drug every 2 weeks following the loading dose, we saw persistent complement knockdown. Patients received the therapy for 6 months and then had a washout. We saw there was persistent knockdown for about 2 to 3 months following discontinuation of the therapy. Now, we also found that there was a reduction in C3a levels in the brain, CSF, which suggests that there was reduction of complement generation in the brain and the spinal fluid, because this is thought to be generated by astrocytes. As a result, and we'll talk about the efficacy in a moment, seem to suggest that there's prolonged effects that occur, and we are in the process of evaluating whether or not the schedule of medication administration can be altered given the long effects of administration. We're hopeful perhaps that the infusion protocol might be extended between doses, or the infusion time may be shortened. Again, this still requires further work to determine. So in these patients who had early symptomatic or late prodromal Huntington's disease, we found that during the course of the 6-month infusion period, and even beyond in the 3-month washout period, there was relative stability of Huntington's symptoms and signs as measured by the complement UHDRS, as well as the TFC, as well as other subcomponents of the composite UHDRS. And this is true when we compare our group of 24 individuals against a matched group of individuals from the TRACK-HD cohort. Now, if we subdivide our patients by those who at baseline had a higher C4a to C4 ratio in the spinal fluid, suggestive of a higher degree of brain complement activation, we take the upper group of 12 compared to the lower group, we see that there's a difference. And those patients who at baseline had a higher degree of complement activation actually had an improvement as measured by the CUHDRS and by the total functional capacity score that was better than the lower group. And this group statistically had a statistically significant improvement compared to the matched cohort individuals. And this benefit outlasted the duration of therapy into virtually the end of the washout 3-month period. So it suggests that in a subgroup of individuals that the therapy may result in symptomatic effects. And in the group as a whole, there seemed to be stability of disease. One would have expected that there would have been progression of disease during the 9-month complete study observation period. This monoclonal antibody looks promising in that we saw complete target engagement. We saw biomarker data suggestive of reduction in neuroinflammation. Everyone is always very interested to know what the NFL levels did, and these remain stable in the entire group, and so far in the subgroups, as far as the data analysis proceeded so far, compared to the TRACK-HD matched individuals. So we did not see a reduction in neurofilament light in this fairly short study, but there are promising results overall in terms of the clinical benefit and the fact that patients remain stable clinically throughout the time course. And it seems that we may have identified a biomarker of response to this therapy in that certain individuals, as indicated by the high baseline levels, a C4A to C4 ratio, may be more responsive because they have more neuroinflammation going on, at least looking at this biomarker. So the next steps will be to begin further design of a potential phase 3 clinical trial that is a double-blind placebo study going over a much longer period, at least 12 months, and potentially 18 or 24 months, and potentially using this predictive marker of higher complement activation of C4A to C4 ratio as an inclusion criteria for the trial. Again, we are still evaluating further our data, looking at more biomarker information, but the current plan is to hopefully begin a phase 3 trial in 2023.